Good afternoon, everyone, and happy Tuesday. I think that we have a great conversation lined up here with two of my favorite partners in the industry, Claudio and Tony. And maybe kind of before kicking things off, we're going to do a quick round of introductions. I am Sam. I am the Executive Vice President of Growth at Spark Advisors, and I'm joined on stage by Tony Feijoo and Claudio Arellano. Is that pretty close? I tried to
close enough.
That was close on both.
Great. And I've known both of them for a few years at this point, and great guys, terrific partners, know a ton about this agent and provider partnership relationship that we're going to dive into here, and really excited to pick their brains and frankly share some of their knowledge with all of you. What I wanted to kind of note is that we'll obviously have a conversation up here. There's going to be a QR code that's going to be rotating on the side that as questions come up, if you have anything that you want to kind of throw over our way, feel free, put in the QR code. You're able to throw in your question and it'll pop up on the screen here. If not, you're also totally able to raise your hand and we'll kind of do it the old-fashioned way. And so with that being said, maybe before we kind of jump into the relationship that you guys have and the partnership that you guys have, Tony, maybe give us some background on yourself and then we'll follow up with Claudio.
Yep, sure. My name is Tony Feijoo. I have been in the health insurance space for about 22 years. I started first as a marketing consultant for payers in South Florida, developed a white brand label for a medical discount plan, and saw the writing on the wall early 2000s where I was certain that there was going to be healthcare reform in this country, and decided to look into that business, and there was this history. Our partnership now goes about to be 5 years this year. Yeah. And I guess we'll talk a little bit about that in a second, how we met and how this thing started.
Good afternoon, everyone. My name is Claudio Arellano. I'm the CEO of Associated Medical Care. Been in healthcare for 29 years. Started as a customer service rep in a health plan at 18 years old. So I've been literally my entire professional career in healthcare. I've worked in a health plan setting, a hospital setting, and I've been on the provider side of the fence for going on 18 years now. I've always felt that provider and sales is a symbiotic relationship. They work hand in hand, they feed each other. And this is how this partnership was born, and we'll get into that. But thank you for having us. Thank you for joining us today.
Yeah, thanks for being here, guys. We appreciate it.
All right, so I think it's no secret that the agent-provider relationship is a critical one when you think about the growth and the care coordination that needs to happen across Medicare. And I think that it is rare to see such a sophisticated partnership come up. And with Tony and Claudio, your relationship, your partnership is so unique. Would love for you to share, what was the genesis of it? How did it come to be? What does it look like now? Walk us through kind of what your specific partnership looks like today.
Yeah, sure. So I forgot to mention that I run the sales side for the company. Claudia and I know each other for a little bit over 13 years. We knew of each other in the market. We just had never crossed paths. And we became very good friends, solving market problems. I was running sales for an agency, and he was running the largest Molina MSO, IFP MSO in South Florida, and we became very good friends. After that, we had...
Gotta tell them the exact story, though, how we met.
All right.
What you said to me.
Okay. We're South Florida guys. So I had an issue with one of my doctors, and they told me, you gotta go see Claudio. And so I went to go see Claudio at the MSO who had the group had just purchased him. And we sat in a room, and the first thing out of my mouth was, don't ask me for $1, and I'm not gonna ask you for $1. And he's like, wow, that's refreshing in South Florida. And we became very good friends since then, because we knew that we had the same values, right? For us, the efficiencies and doing what's best for the patient has always been what's driven us. And then we helped launch an MA startup in South Florida about 6 years ago, and that was a total disaster, not because of us. And
They did everything we told them not to do.
yeah, they checked every box, and we had lunch this is a funny story, at a Mexican restaurant. The day that we retire, our book is going to be called Two Bald Guys in a Mexican Restaurant, because we kind of plotted our ideas, right? We always saw that there was a dysfunctional operation in our industry where sales and network are fighting all the time, and we just didn't understand why that happened. And then the provider, who's so important, was also like this hanging entity. And we said, we should do something together. And where you're going to be, utilizing your experience in running networks and my side on sales. And our goal at the very beginning was to focus on MA only. We wanted to run an MSO and an FMO that was based on MA. And then eventually getting into the actual sales distribution by partnering with local providers, or even starting provider offices. And then something called the Affordable Care Act happened. And we couldn't do any MA. We were just overwhelmed. And both companies grew very quickly on both the distribution side and the network side. And it wasn't until about 2 years ago that we were able to focus on another startup in South Florida that was launching an MA plan. And that's when we really started focusing more on the growth of the Medicare Advantage and the MSO and the networks together. Anything you want to add to that?
Yeah, I just, when we sat together, the two bald guys in a Mexican restaurant, right? To touch on Tony's point, our industry is so fragmented, and on the network side and the sales side, I can understand from a health plan's perspective, there's a lot of compliance and regulatory issues, right? There can't be too much interaction between the two. But when we sat down, we said to ourselves, okay, what's the lifespan of an enrollee? And the lifespan of an enrollee is, first, the salesperson touches the member, right, and helps them get to the right product. Then we have a management company, such as the MSO, that does the managing of the patient's care, right? We work with providers, we work with health plans, we work with sales folks to make sure that that consumer is getting all the care that they need. And ultimately, that patient is retained once they build that provider relationship, once they have that relationship with their primary care doctor, and that primary care doctor is the one that keeps them. That's the one that tells them, this is the plan you're gonna go to because this one's giving me too many headaches. So when we looked at that lifespan of the patient, we said, this is our business model. You've got sales covered, I've got network covered. We need to build that third piece, which is what we're doing now, that third startup, and we're integrating the three platforms together compliantly, right? There's no sharing of data, but we're integrating the three platforms, and we're making it work. I mean, we're seeing it work. We're dealing with thousands and thousands of patients. We're creating efficiencies through technology, and we're seeing that the model works because we're guiding that consumer from point A all the way to point Z, which is ultimately their healthcare.
So Claudio, question for you, since we use the term MSO a lot in the industry, and maybe not necessarily everyone knows exactly what it means. Maybe you can elaborate on the definition, for instance, of an MSO, but I think more importantly, how an MSO can really be leveraged from a sales capacity when thinking about the Medicare market.
Sure, absolutely. So an MSO is an acronym for Management Service Organization. And basically what we are is we are an intermediary between a health plan and primary care providers. As we know, insurance in general, it's a risk-bearing business, right? Any kind of insurance company, that's what they do, they take risk. So what health plans try to do is they try to pass on that risk to the provider entities, because ultimately the provider entities are the ones that are servicing that consumer. The health plan is just an administrator, right? So we serve as that intermediary that takes on that financial risk from the payers. Most primary care providers, with the exception of the large entities like the One Medical, the Village MDs of the world, right? They don't have the infrastructure that to manage the risk of the population that they serve. They don't have the infrastructure that does the patient outreach. They don't have the infrastructure that does the clinical overview of the patient, the reporting overview of all the metrics that have to be monitored and met throughout the lifespan of the patient while they're on a policy. So we are that solution for the carrier. The carriers will look to organizations like ours and say, can you help us build a primary care network and manage a primary care network? And that's what we do. And that's why we're called a management service organization, or an MSO. There's also another acronym called IPA, which is an Independent Physician Association. Sometimes you'll hear that term interchanged between the two, but it's basically the same thing. An IPA is a collaboration of independent practitioners that formed this association to serve the consumers and the health plans.
Well, so maybe now expanding on that, maybe Tony, when thinking about your sales approach, right, or what you're doing from the sales side of things, how do you, leverage, Claudio's MSO, for example, in order to help drive sales, drive growth?
So that's a great question, and there's a couple of things that we lean on each other. So and one of the reasons why we got started, and for the folks out there that are in sales, you don't need to have an MSO partner to try these ideas. You just have to think about how anything we tell you here today, you can implement it in your daily business. But one of the things that we always saw. An agent goes to a physician, and it's a great fit for X plan. And good luck with getting that agent, to contact the payer and getting that contract. It never happens. We saw it in my career. Insurance payers leaving thousands of lives on the table just because they couldn't figure out the networking side. So it was one of the initial things that we said we need to work together, because the biggest referral for the MSO network are the agents. The agents are the ones that are bringing doctors on a daily basis to him, and that agent now is is the bridge. So whether the agent is part of our FMO or not, because we work completely separate companies. It could be an agent that's in our sales organization, or it could be an agent that's in another FMO or another organization. Bring him the doctor, and then that agent becomes the official rep in that practice. And it is how great MA books are built. The ACA is now going in that direction. It's not there completely, but that's one of the ways that we leverage each other. And an interesting development is the agent's role now with the insurance carrier beyond being a sales rep. A lot of you folks out here that understand MA know about risk, and maybe you're new to the ACA, or you're not, but the risk in the ACA is incredibly damaging if it's not properly managed. So the networks are now seeing the value of the agent and the clinical life of the patient. And all of these things make us more valuable to everybody. Because when we're able, and this is, you and I were talking about this earlier, when you're able to leverage strengths, you're bigger than just one. So the insurance payers, relying on the agents and on the networks and on the provider. 'Cause ultimately, what we're doing is serving members, right? Never lose sight of that, right? Ultimately, that's what we're doing. We're helping make someone healthier, right?
So maybe let's talk mechanically for a second, right? And so, for your average agent, right, that may or may not be with your FMO, how can they work with your MSA to actually drive, more sales? And you kind of like alluded to, then being the representative in that provider's office, for example. Like, how does that kind of like full circle ultimately manifest itself?
So, this is a question for you, but I'll start it and then I'm going to give it back to you. There's a little bit of grassroots, right? I mean, you need to, we need to let the folks know about the MSO in the area, and we've done it, when we've expanded to other markets. But for the average agent that perhaps might not have that relationship, you can build one by asking the right questions at the provider's office. Because you might ask the provider, are you working with an MSO? And you might find one. Well, can I get a hold of that MSO and have a conversation with them? And because in South Florida, it's how it's happened, and we're seeing that trend go to other areas of the country, where maybe 5 or 6 years ago, if you were an agent, maybe a little bit more, walking into a doctor's office, they would go, "What are you doing here? What are you doing here? You're an agent. What are you doing here?" And that's changed, right?
Yeah, so I'll just add to what Tony's saying, right? That the agent relationship with the provider is really important. That's why we're having this panel, right? The providers, as I said a little while ago, once they establish a relationship with their patients, they deal with a lot of administrative burden, right? Which is why the MSO exists, right? We help with some of that admin burden. And that admin burden, unfortunately, is a trickle down, right? It comes from regulatory bodies with all the rules and regulations that have to be followed, and it trickles down to CMS, and it trickles down to the health plan, and it ultimately trickles down to the provider, right? So, one of my favorite examples that I'll give that is as clear as day is, there are requirements for physicians to document patients' conditions. And these requirements, specifically on Medicare, is twice a year, right? So if a patient has a condition, they have to make sure that they see that patient at minimum twice a year, and they document that condition twice a year. So here's my favorite example, an amputee, right? We're not crabs. We don't grow our limbs back. However, CMS requires that provider to make sure that when they see that patient twice a year, they are documenting that this patient is an amputee, right? So that's an example of just admin burden that the practices have to deal with, right? So what ends up happening is that the practices will begin to, or the provider, the doctors, right, they'll begin to formulate, processes with health plans that make their life easier, right? Of course, we know there's many things that fall into place when a patient makes a decision on what carrier they're going to enroll with, right, such as benefits, cost, things like that. But ultimately, that provider says, okay, if I accept 3 health plans in my practice, and health plan A makes my life so much easier, I don't have issues with referrals, I don't have issues with authorizations, I don't have any kind of admin issues with my patients and making sure, that they go see their specialists. And health plan B, well, they're kind of in the middle, and health plan C, they make me jump through hoops to send the patient to go see a cardiologist. Eventually, what that provider will start to do is educate their patients and say, listen, you have 3 health plans here, they pretty much all give you the same thing, except this one makes my life easier. So how does that provider make that consumer evaluate that health plan? It's through the sales channels, right? So if that provider has a relationship with an agent, that provider is going to have their office manager call Mr. Agent and say, Mr. Agent, I have a consumer that's interested in evaluating some other plans. Can you please meet with them to have a conversation? And in South Florida, which we'd like to, warmly call the jungle, we have provider practices that have an office space within their practice that's dedicated for an agent to come in and spend the whole day there, right? Because they're just feeding them the patients, right, that are interested. And I'm using that word feeding loosely, right? It's all done compliantly, but they're giving them the consumers to go in and help them evaluate. So, when that provider and that agent have a great relationship, then that agent becomes a resource for that provider. And sometimes when there's a new carrier in the market or there's a new benefit in the market and that provider doesn't participate in the network, that agent ends up helping that provider obtain that contract with the payer, either through a direct contact with the payer, or when they work with MSOs like us, they'll come to us and say, listen, I'm working with Dr. John Smith. I need to get this doctor on this contract. And that's what we do. We help them get on that contract and make their life easier across the board.
So you mentioned jungle. I'm going to call it the gorilla. I think in every conversation that I have with agents, especially when kind of contextualizing this, agent-provider relationship, inevitably, as you guys mentioned, the whole kind of topic around compliance comes up, right? And I'm curious to get your perspective of how you've solved that within your own relationships and partnerships to make sure that as you're thinking about, in a lot of ways, working with providers to drive Medicare sales, how do you do so compliantly to make sure that we're all tick and tied when thinking about CMS regulations?
It's simple, Sam. CMS makes it very clear as to the do's and the don'ts. We stay away from the don'ts, far away from the don'ts. And we try to identify any rogue players that are, breaking the rules by not complying with what CMS is requesting. The reality in our market is that the physicians are the first agent. What Claudio just explained quite elegantly, it's more like, Mr. Consumer, this is the plan you're going to go into, right? And it happens in our market every day. As long as we follow the guidelines of contact and where to write the business, making sure SOAs are properly addressed, there's no compliance issues with writing business using the physician as a referral system, because our most successful agents are the ones that have this kind of relationship, and we are in a business of relationships. The doctor, or the practice sees the agent as their growth entity, and their retention entity, and they're using them more and more and more. And it's why I see, and I've pitched this to several payers, and so has Claudio, the agent's increased role in the process. When he's talking about those 2 visits a year, that sounds simple. Go and get documented again. Sometimes a practice they don't have the resources, and it's the agent who's getting involved to get that patient to go back to the physician. And there is something very interesting happening in our industry now, where you will see that continue to evolve. Where us as sales arms are going to be more involved in the clinical side. A lot of us are already doing it. I know that agents getting phone calls in the middle of the night. What do? I'm feeling sick, or I ran out of my medication. How should I handle that? So it's kind of happening already. But I think that beyond the HRAs that we do, there's going to be much more involvement of the agent in the health life of the patient.
Claudio, compliance. What are your thoughts from the provider side of things?
Fortunately, the compliance world on the provider side is a little bit more relaxed than it is on the sales side. So obviously we follow the rules and we educate our provider partners on the do's and the don'ts. But CMS is now breathing down their neck as much as CMS does on sales side of the world. So it's a little bit easier for us to navigate through those waters.
Right. They have the providers can direct contact consumers to attract them to come to their practices, and we all know that we cannot do an outbound unsolicited phone call or contact to a CMS to a Medicare recipient.
All right, so you mentioned also something as it relates to this ongoing trend in the industry as the local agent is really kind of becoming this like entry point to care, right? This really critical entity within the healthcare industry that are ultimately becoming more clinical in nature, right? And so when thinking about the agent that maybe is on the sidelines today and thinking about how they can involve themselves more so in this provider relationship and get more comfortable being this clinical, entity in a lot of ways, what recommendations, what advice, what perspectives would you provide someone to even kind of like think about going down, this again more provider-focused path?
Well, it's focused on the member, Sam. When I was I'm still an agent. I want to say when I was an agent, but I've always been an agent. And we were handling in those days smaller books. You made sure that your consumer had their first appointment at the doctor's, and you were highly engaged. That you got phone calls all the time. When the ACA exploded in growth, and Medicare did too. It was harder to do those things. And that's why technology is playing such a great role now, and we can talk about that in a little bit if you want to, on the how the agent now can be more involved in the life of their patient, right? Because you have to be. I mean, our health system, and I'm not a doomsday guy, but I'm gonna say a doomsday comment, can collapse because if all of you guys are listening to all this growth and 10,000 people are aging in every day, and we're going to have one out of 3 people in this country going to be over 65 in the next 15, 20 years. How on earth are we going to manage that as a country? And that doesn't even touch on the IFP world and all those the struggles that the Affordable Care Act is having on the risk side. Something that you're very well aware of, and I think that the missing piece is integration. Using the network and sales to really make sure that patient is walking through, and it starts at the member level and at the provider level, Sam.
Yep. And so, kind of taking you up on your offer to talk about technology a little bit. And so I know from experience working with you guys, you are by far and away the most advanced when thinking about all of the modern tools and services that are available to allow your agents to work with providers and providers vice versa, right? Share with me or share with us, right? Kind of what this now new tech landscape potentially looks like that you're optimistic around, that you've seen to be successful for your businesses, that's allowed you guys to be successful in kind of this new age of technology.
Well, we talk about this all the time because we realize that technology is going to play a great role. It's going to be the factor X, right? It's not that you think linearly and you say, wow, things are going to just break down here, but it's always some great idea that says, no, we can jump that. On the MSO side, this is an established industry, and Claudio has amazing software that he uses to report to the physicians, and now on the sales side, it's been a little fragmented, right? You've got guys like Spark that are really rethinking how to provide carriers and tools to the agent. I think we've become partners because of that, because we see the importance of technology. Something that we've done, and something we've done, and we were talking last night about this. We were talking about Zoho, for example, a CRM. I encourage agents and agencies to try to use a CRM system and see if that CRM system can help you solve your day-to-day problems. So, for example, in the referral business, you'll have an agent that either brings a doctor or is working with a doctor, and they're bringing patients in. So you'll have an agent maybe refer 30, 40, 50 lives to a physician, and it's very easy for that member to be sold by someone else, or if the doctor says, hey, his example, plan A, plan B, plan C, plan A helps me a little bit more. So we saw a lot of noise in South Florida over that. So our internal team developed a tool that allows a doctor to see what agent referred a member to them. So if the member has any issues, the practice calls the actual agent who sold it. So it's one of the small examples on how we're trying to adapt technology to close the gap in those relationships.
Great. I'm going to pivot a little bit because we got a question that came in from Anonymous, awesome name. Can you elaborate on how you help the physician get contracted on a specific plan?
So I guess there's two ways that I can answer that question. The easiest way for us to help a provider get contracted is if we have a relationship with the plan that they're interested in. The MSO business is a very regional structure. So, if I have a contract with United Healthcare, for example, I may have a contract with United Healthcare in just whatever counties in the state that I'm in, right? So I may not be able to work the entire state or on a national level. So it's very geographic. It's very regional. The type of contracting that we employ. But if we have a relationship with that payer and that provider happens to be in that market that we're representing, then it's very easy for us. We help the provider through the credentialing process. The credentialing is what would be referred to as the onboarding process in the sales world, right? They verify their schooling, their education, their training, their licenses, their insurance, malpractice insurance, and things like that, whatever's applicable in the state that they're in. So that's kind of the easy part. The hard part is when we don't have a relationship with a payer that they're interested in. That being said, though, we don't shy away from those because we take it as an opportunity for us as an MSO. If we're getting a lot of leads from the sales channel for a specific health plan, then we start to say, okay, there's an interest here, there's a need. Then we start knocking on the health plan's door for an MSO contract for us. But even if there isn't, and it's a one-off here and there, we'll still help that provider or we'll still help that agent and at minimum guide them through the enrollment process with a health plan. Most health plans have on their website a join our network link or something like that. So we'll kind of help them walk that provider through that process. And that's basically the steps that we take to bring them on.
So you mentioned the payer and the health plan a number of times in what you just shared there. Why, from the health plan payer standpoint, do they want to work with MSOs like yourself? What's the value of it for them?
So it really boils down to passing the financial risk, right? Health plans are looking for partners that they can pass financial risk down to, and in order for them to do that, the entity that's going to take on that financial risk has to have the infrastructure to do so. And most independent practitioners just don't have that infrastructure. They don't have a clinical team other than the doctor. They don't have a customer service team other than the office staff. They don't have the reporting analytics that are required to manage your patient population. In essence, an MSO is a small health plan, right? We operate in very small, thin margins, very tight infrastructure, but going back to technology, right? We also employ a lot of technology to create efficiencies within our infrastructure to be able to create and pass on those efficiencies to our providers. But that's the reason why a health plan would want to work with us, because from a health plan's perspective, besides passing on the financial risk, if there's an issue, if they have a network need, if there's a network gap, then they go to one entity. They'll come and knock on our door and say, hey, we need help here, versus them having to hire consultants or making sure that they have enough reps out in the field knocking on providers' doors.
And so maybe quickly, because I do want to get to this next question here, when you're kind of getting that push from the health plan or the payer in that regard to go contract with a specific group of providers, right? Or they've seen a network gap, what is typically that conversation that your team is having with the providers to actually bring them on board through your MSO?
So generally, when a health plan is knocking on our door because they need a network deficiency filled, it's because it's usually tied to some sort of expansion. We work predominantly with primary care providers, although we work with specialists because of the primary care providers. Our focus is primary care. So generally, primary care is one of the very first things that health plans will contract for when they go into a new market. Before they apply for their HMO license or their regulatory approval, they have to build a primary care network. So when they're already working with us in a specific market and they want to go into a new market, they'll come to us and they'll say, listen, we're going to a new market. Can you help us go there? Do you have providers in that area? And if you don't, are you willing to go out there and help us recruit? And so we do that job for them.
Awesome.
I wanted to add something really quick, Sam, on the question on how to help get the physician contracted. My advice to you guys that are out there is you can reach out to the plans and ask them if they're working with an MSO network in the area. And can you get a name for that person? That would be a great contact for you, and it's really like practical things to do. So we want to be as specific as possible in giving you guys advice on how to do this. Some plans will give you the information. They'll say, look, we're not contracting any doctors now, but maybe you can talk to this MSO. So the plans can be a good source of information. Become good friends with their local sales rep. The network guys from plans are in another world. You won't be able to reach them that easily. But your biggest ally is the district manager or the director or your local rep, who will be able to help you with the kind of stuff. At least put you in touch with someone. Whether they'll get contracted or not, it's really up to the plan. But reaching out to them to get them to give you alternative distribution systems. Well, they'll tell you, oh yeah, we're not contracting directly, but you can go talk to this MSO over here. So I wanted to make sure that I added that.
Yeah, that's a great point. And super helpful just when thinking about kind of like the tactics that someone can deploy here. Right. So the next question that we have coming up is, I think, in relation to sales, and maybe Tony, this is a question for you, but kind of going back to the technology piece. What CRM do you use, and are there any HIPAA restrictions, or is that a non-issue given this is a non-patient relationship?
So we use several CRMs, unfortunately, and we're putting that all together now. But we have a call center operation that we're running on Salesforce. Our agency runs on Zoho. We are now building our own proprietary on Microsoft.net. For enrollment purposes, everybody here knows Connectiv and Sunfire, which are, glorified CRMs, and so is Health Sherpa for the ACA. And yes, in your question, whoever wrote it, there's no HIPAA as long as there's no patient information. But if there is, whatever CRM you're using must have a BAA agreement that is ensuring the protection of the data, and most all of them do. Most all of them do.
And you noted before that the data from your sales engine is never being exposed or flipped over directly to your MSO in any capacity.
That is correct. So we operate in different offices. We have complete different systems. Because that's the compliant way of doing it. So we share zero data between our companies. We don't see their data, they don't see our data.
Great. Any other questions for the crowd while I also take a drink of water? Yeah. Joanna?
It's quite simple. We usually, and it's a great question too, because we get referrals from the MSO, and obviously an agent can always come to our offices and come and join us under the sales organization. We haven't really talked a lot about the third leg of our business, which is growing now. We started it a little bit over a year and a half ago, and it was part of our business plan when we got together, which is, within Claudio's network, we've identified and or started our own division of healthcare delivery. So we now own and are expanding our own brand of primary care. And we're in South Florida, we're in Texas, we're in Georgia. And it's the fulfillment of the business model that we wanted, which is taking care of that member on all three spaces that touch the member all the time: the sales, the network, and the doctor. But we doors open for any agent that wants to work with us in any part of the country.
Any other questions? Oh.
We had a meeting a little while ago about that. We had a phone call. You want to take that?
Yeah, I think I'd like to take that one. I would ask you to find the doctor that recently merged with one of those large systems and ask him how it's going. And
That's a sarcastic answer.
that'll give you your answer. Yeah. So yes and no, right? I think there's many factors that play into that decision, right? One of the factors obviously is geography. Where is this practice located? And what is the patient density in that area? Is that practice struggling to grow? There's many factors that come into play. But the reality of that and why a practitioner makes that decision is it boils down to all of the admin burden that falls on that practice, right? They just don't have that support that's going to help them grow, that's going to help them manage their patient population. They just don't have that infrastructure. So a provider that generally says the front office is, wife or husband is usually the office manager and the doctor is the doctor, and then they've got 3 or 4 personnel to help them run the day-to-day operations. That practice will say, you know what, I'm better off going into a large system because I get all the admin help and I get rid of the operational headaches. I'm a 9-to-5 employee per se. 9 to 5 is not really the case for them, right? But they get rid of that headache. So, there's always going to be that shift. However, what we're seeing, right, is that what ends up happening is that when that provider turns into one of those institutions, that patient-physician relationship disappears because that patient no longer has direct connect to their provider. Now that patient is going through a system to make an appointment that may or may not land with that provider, may or may get with another provider that's in the rotation of that institution. So that patient relationship with that provider disappears, and what ends up happening to that patient is they say, you know what, I loved my doctor, but I'm not going to that place. I'm going to find me another primary care provider that has, that has that hometown feeling, right? So we're seeing a shift in that. I think, or we think that the independent practitioner is going to have a space in the market. Again, geography plays a big role in it, but we think that that physician and patient relationship is going to have a space. I think that the way that we're going to continue to help them solve that problem to prevent them becoming an institution is creating efficiencies for them to see their patient. We know that the Medicare member of today is not the Medicare member of 10 years ago. The Medicare member of today is looking at their smartphone and wants a quick appointment. I want to go in and out because I've got too many things to do, right? Whereas the Medicare patient of 10 years ago was a different patient, right? So we come in and we help that practitioner create those efficiencies so that they do what they went to school and trained for. Be a provider. Take care of your patient. Let us do that admin work for you, and we'll help you stay in that environment so you keep that relationship to your patient.
When you look at data now, and the growth trend is just gigantic. By default, there is going to be room for all different ways of delivering the healthcare. You will have the hospital systems, you will have the Village MDs, One Medicals of the world that all these large organizations are purchasing, but you're going to also have room. And to his answer of geography, whether you're in a metro area or a rural area, you will have room for the small practitioner to operate, provided that they are part of some network that helps them practice correctly. But it's inevitable that there'll be some more of that happening. But when you look at stats, I think I saw this a week ago. I think it's up to 26 days now is the average wait time to see a primary care doctor in this country. That's crazy. A specialist, 60 days, 90 days, 6 months. This is happening now. Now, dealing with hospital systems. You'll call a hospital system now to go see a specialist, and you'll be 6 months out. You'll be 9 months out. So the needs of the consumer are not to be ignored in the way that it's going to be delivered. So that's why we strongly feel that the mid-size office is going to have a place in this country versus the big hospital systems or the conglomerate networks that have 3,000 patients assigned to one building, and you got to sit there for 2 hours to see a doctor.
Yeah.
There's a couple of publications, and we can offline exchange emails later. Modern Healthcare is one. It's a great organization. I'm a nerd, so I read insurance every day of my life. Yeah, it is. I encourage all the agents here, become health insurance nerds. Knowledge is power. So Modern Healthcare is one. Kaiser publishes great data all the time. But I'll give you some places to look at. You're welcome.
All right, and so we got a couple questions here. So first, can an agent become an MSO? And if so, how do you become one?
So I guess the first question, can an agent become an MSO? Yes, right? Anyone really can do it. Depending on the state, there are some regulatory steps you have to take. Because there's a fiscal responsibility attached to it, especially when you're going into a financial risk arrangement with a payer or a value-based contract with a payer. So there are some steps that you need to take. So the answer is yes, you can become. What I would say is there's a lot that goes behind the day-to-day operations of an MSO. The two bald guys are up here talking, but our team is down there, and they're the ones that do all the heavy lifting, right? It's not just us. We're the pretty ones, but they're the ones that do all the dirty work, right? They're the ones that are out there meeting with the providers. They're going through the reports. They're having the clinical conversations. They're having the pharmacy discussions. They're looking at the analytics. So there's a lot that goes behind the infrastructure. And so, those are things that you need to look at. But you can do it. It can be done. You find the right people to help you put the team together, and it can be done.
Well, that was what I was going to say, because we get that question all the time, right? Hey, I want to be an MSO. So the answer is yes, but you must put a team together. I mean, we've got doctors in our staff, nurses, analysts. It's a big deal. Call center, so it's a big organization, but it is possible to do.
All right, and so a couple more questions here. So this is from Brent. How are you as a network helping the doctors mature out of the grind of fee-for-service and into value-based care? And how can agents help with this?
That's a new one, value-based care. Yeah. That's a new word.
That's the new acronym.
Yeah.
So the way that we help them, fee-for-service is an environment that, it's not going away, right? And especially in certain markets, it's just the way that the health system is developed. So the way that we help that provider with that day-to-day grind of the fee-for-service is one of the tools that we offer to them is revenue cycle management services. So we have a billing company that does all of the billing, all of the encounters, all of the coding, all of the billing, the collections of the patients and the bills and stuff like that. So we help them with that to help, again, get rid of that admin burden where they're not worried about what's my outstanding AR out there. Their job is to see their patients. So that's one of the ways that we help them. And how can an agent help with value-based is what we talked about earlier. When you're enrolling that patient onto the plan, help them make their first appointment. Call the doctor with the patient and say, Mr. Dr. Smith, I'm here with patient, Jane that needs to make an appointment with you. Can you help me make that first appointment? That's how you help that provider as an agent with the value-based, because the whole point of value-based care is the quality of life of the patient, right? And how do we give patient quality of life? Make sure that they're getting seen, preventive medicine. You're catching things before it gets worse. You're not going to the ER. You're taking your meds on time and things like that. So that's how an agent can help get involved in that patient's, at minimum, first appointment with their primary care doctor.
I think that's great, and it probably also helps from a retention standpoint as well.
Absolutely.
All right, and then last question here, and this is for Tony as we're running up on time. So Tony, this is from Taylor. What type of marketing activities is your agency doing to help grow and add to your doctors panel?
So thank you for the question, Taylor. We have a team, internal team, and we teach our external team to actually go out and visit practices. And sell your value to that practice and why you can do something different for that practice and how you're going to help that practice grow. We do events and practices. I mean, we all know all this stuff. But in those visits, again, that we identify somebody who might be a good target for the MSO, we refer them to the MSO. And that's how we have grown our doctors panel over the last 4 years to a significant number, and it's come through the sales arm. Sales arm has been invaluable to the growth of the MSO, because we're out there talking to physicians. Yep.
Great. We are officially at time. So everyone, thank you to Tony and Claudio. This has been
Thank you, sir.
tremendous, and thank you for all the information.